Hello, everyone, and welcome to today's webinar, Breaking Barriers in STI Clinical Management, Addressing Resistance Challenges and Incorporating New Diagnostic Approaches. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Applied Biocode. To learn more, visit apbiocode.com. We encourage you to participate today by submitting as many questions as you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. And with that, I'd like to now welcome our speakers. Dr. William Geisler, Professor of Medicine and Epidemiology in the Division of Infectious Diseases at the University of Alabama at Birmingham, Director of the UAB STD Program, Research Director of the UAB Diagnostics Mycoplasma Laboratory, and UAB Assistant Dean for Physician Scientist Development. Also joining us here today is Dr. Barbara Vanderpool, Professor of Medicine and Public Health at the University of Alabama at Birmingham, Director of the UAB STD Diagnostics Laboratory, and President of the International Society for STD Research. For a complete biography on our speakers, please click on the Presenter tab. Dr. Geisler, I'll pass it over to you to get us started.
Great, thank you for the introduction, Kaylee. And I want to show everybody first to my financial disclosures for research grants, consulting, and speaking honoraria. And then next, I will show you the disclosures of my colleague, Dr. Vanderpool, for her research grants, salary, and consulting. So these are the learning objectives for today that myself and Dr. Vanderpool are going to cover the material for. So we anticipate that you should recognize the key clinical manifestations of common curable STIs. We'll primarily be talking about chlamydia, Neisseria gonorrhea, Mycoplasma genitalium, and Trichomonas vaginalis. We're going to talk about the prevalence of antibiotic resistance mutations, primarily for Mycoplasma genitalium and Neisseria gonorrhea. We hope you should become familiar with the options for the different types of STI molecular tests, including those that have resistance markers that would help to guide therapy. And then we're going to review recommended testing and treatment approaches based on CDC guidelines for some of these common curable STIs. And I am going to tag team with Dr. Vanderpool. I'm going to start talking about the clinical manifestations. Then I'll be handing it over to her to talk about antibiotic resistance and the specific STI test. And then I will wrap it up talking about the recommended testing and treatment approaches. All right, so let's talk about clinical manifestations of some of these common STIs. So in men, one of the most common clinical presentations of these common STIs is what we call urethritis. But I also want to note that this can be seen in women as well. In terms of the STIs that commonly cause urethritis, they are chlamydia trachomatis, Neisseria gonorrhea, Mycoplasma genitalium, and Trichomonas vaginalis. When a patient presents with urethritis, they are going to have symptoms such as discomfort with urination, and they may have urethral discharge. And when we perform an exam of the genital area in those who have urethritis, we may find some redness of the meatal area, which is the opening of the urethra, and then we may see some urethral discharge. So in men, typically who present with urethritis, if we have access to doing a urethral gram stain, that would be ideal because we can look for not only the presence of white cells, but also the presence of gonococcal-like bacteria. But ultimately, whether we have the gram stain or not, we do have options for clinically diagnosing urethritis, which includes either doing that gram stain showing the white cells. As you can see over here, there's a bunch of small cells with multi-lobe nuclei. Those are white cells. If we see 2 or more of those per field on high power field, that would be consistent with urethritis. Or if a person has pyuria in the urine, or we can see urethral discharge, any of those would lead us to clinically diagnose a person with urethritis and then to do the recommended testing and treatment for urethritis. In women, one of the more common clinical presentations of these common STIs is what's called cervicitis, which is an inflammatory condition of the cervix. And most commonly, this is going to be due to chlamydia, Neisseria gonorrhea, and Mycoplasma genitalium. And symptoms of women who have cervicitis, and they're somewhat nonspecific, but include vaginal discharge, pain during sex, and irregular bleeding in between periods. When we do a pelvic exam and insert a speculum and look at the cervix in a woman, we may see cervical discharge as shown in that top picture, or we may see easily induced endocervical bleeding when we insert a Dacron tip swab to collect a specimen for testing. It may start oozing blood, as is shown in that bottom picture. So clinically, we diagnose cervicitis in a woman based on either finding that cervical discharge or finding the easily induced endocervical bleeding when inserting a cervical swab. Now, vaginal discharge itself is a very common symptom in women, and most commonly the causes are going to be trichomonas, bacteriovaginosis, or candidiasis. And of those three, trichomonas is an established STI. But it's important to understand that other STIs that cause cervical infection can lead to vaginal discharge. And so women, again, can present with vaginal discharge when they have STIs like chlamydia, gonorrhea, and mycoplasma genitalium. Besides the vaginal discharge, they may have other accompanying symptoms, including vaginal odor, irritation, or itching. And unfortunately, even though sometimes those other symptoms might suggest one cause over another, you still need to do the evaluation for all of these common infectious causes. Clinically, we would base vaginal discharge sometimes just based on their history, but ideally, if we can do an exam, we'd like to demonstrate the presence of abnormal vaginal discharge. And then from that discharge, one of the things we can do kind of in the clinic easily is to collect a sample of that vaginal discharge fluid and look at it under the microscope to look for findings that would be consistent with trichomonas, bacteriovaginosis, or candidiasis. But I want to point out that the wet mount is insufficient to diagnose chlamydia, gonorrhea, or mycoplasma genitalium. So in women with vaginal discharge, they will still need molecular testing that Dr. Vanderpoel will talk about later to diagnose some of these common STIs. Now, there are certainly other possible clinical manifestations in men and women for common incurable STIs. In the case of men, very rarely they can get infection of the epididymis, which could present with epididymal or testicular pain and swelling. They could get a rectal infection that can present as proctitis with rectal bleeding, rectal discharge, or pain. They can develop pharyngitis. The pharyngitis primarily would be with gonorrhea, which can be often asymptomatic, but could present as kind of a mild sore throat, or in rarer cases, can resemble strep pharyngitis. In the case of women, when the infection spreads to their upper genital tract, they can get pelvic and or abdominal pain, and we would call that condition pelvic inflammatory disease. If a woman's pregnant and gets these common STIs, they can develop perinatal complications such as preterm birth. And then, of course, women, just like men, can get pharyngitis with gonorrhea. Trichomonas, I should point out, does not typically cause rectal infection, so that's something that we are usually not concerned about. One point I really want to make about this slide is that even though I've been talking about common clinical manifestations of these STIs, I think it's important to point out that these STIs are often asymptomatic, particularly chlamydia, mycoplasma genitalium, and trichomonas vaginalis, where in some populations, the majority of patients who have these infections will actually be asymptomatic, which means you might not detect them unless you specifically do testing for them. So I'm going to hand it over now to my colleague, Dr. Vanderpoel, who's going to lead the discussion on antibiotic resistance and then some of the different assays for testing for these common STIs.
Thanks, Will. I do want to talk about antibiotic resistance and the epidemiology of where we see resistance, especially in the US, because that is one of the barriers that we really would like to overcome. And then I will go on to talk a little bit about some of our diagnostic options before I turn it back over to Will. So I'm going to show you a lot of pictures, so just bear with me, but at least they're pictures and it's not a lot of data to look at numbers-wise. This is an image that's been used widely by WHO and by the CDC to sort of describe the evolution of resistance against antimicrobials in Neisseria gonorrhea. So what you see is that once we started using sulfonamides and penicillin, we started seeing different resistance determinants become more and more commonly recognized. So we switched in the 60s and 70s to spectinomycin and tetracycline. But then we started seeing resistance to those compounds. So we switched to azithromycin and ceftriaxone at that time. And I'll show you data about resistance for both of those compounds. Cefixime came on, but then cefixime resistance started showing up about 10 years after we started using it. We started using ceftriaxone, and we started seeing ceftriaxone resistance around 2010. So the point of this is that the further we go in the timeline, the fewer and fewer options we have for compounds to treat gonorrhea with, and the more resistance mechanisms we're seeing. Oops, sorry. Okay, so these are the most recent data from the CDC, and these came out in January of this year. And what you see here is that ciprofloxacin resistant is over 30%. So, of course, we're not using ciprofloxacin as a recommended treatment any longer. Tetracycline resistance, although we haven't used tetracyclines for treatment of gonorrhea in many, many decades, is still quite high. What's interesting is that of these three, penicillin is actually lower because penicillin is used less commonly, not only for treatment of gonorrhea, but for treatment of other things. It's not something that is used quite as much as some of these other compounds for treating any number of infections. If you see azithromycin, which was one of the more common treatments in the early noughts, we see that resistance is not yet above 10%. It is clearly above 5%. And that's the line at which WHO and CDC and European guidelines all say once an organism hits a 5% or higher rate of resistance, you should stop that treatment as the first line of defense. So right now, cefixime and ceftriaxone are what we're using almost exclusively. Now, what you can see if we zone in, because I said 5% is your key marker here, and if we zoom in to see what's going on between 0 and 10%, you can see that we have elevated minimum inhibitory concentrations of azithromycin, not necessarily resistant, but at least elevated rates of having to use higher or loads in order to achieve that clearance. We see that the azithromycin's been quite high, breaking the 5% barrier that we don't want to see until we stopped recommending in 2020 that azithromycin be used as a first-line treatment. And so you can see cefixime shown in green and ceftriaxone shown in yellow still have quite low rates of resistance, and we want to keep it that way. So what can we do to keep it that way? Well, first of all, we have to understand where this is happening. And what we can see here is a pattern with azithromycin that is also reflected in ceftriaxone. And although the y-axes are different orders of magnitude, so that azithromycin goes up to 10% and ceftriaxone only goes up to 0.5%, we see a repeating and recurring pattern. And that is that we see these rates highest among gay and bisexual men. And that is in part from where we do our actual testing. Our resistance surveillance network relies on testing samples from men. And we've tried to get samples from symptomatic men. So we're testing urethral swabs from men who come in with symptoms that we think are likely to have GC. That's in part why you don't see a lot of data from women here, because they're not included in the surveillance process very often. So that is to say that this doesn't exclude women, but we are mostly testing men. But so when you break it out by sexual orientation, you can say that that's a predictor of where resistance will occur first. So that's gonorrhea. Let's talk a little bit about Mycoplasma genitalium. So the first thing that we talk about with mycoplasma is resistance markers that are related to macrolide resistance. So we see macrolide resistance markers all over the world, ranging anywhere from 4 to 100%. Now, remember, these are just genetic markers. We can't necessarily correlate these back to clinical outcomes all the time. And I think that's an important thing to remember. The other thing to remember is that when you look at these numbers for US data that range from 44 to 90%, these are almost exclusively from STD clinics. So this is not a generalized population. This doesn't mean that everybody in the population who has mycoplasma is going to have rates of resistance quite this high, because these range from 44% to 94%. But what you should see here is that it's higher in men who have sex with men. Obviously, it's higher in men who have symptoms than men who don't. But men who have mycoplasma genitalium can be asymptomatic. That's one of the reasons we don't recommend screening asymptomatic populations, is because we don't really understand what the resistance rates are in those populations. If we look at this in a different way, these are data from a meta-analysis that was done in 2020, and they included 59 studies, and 57 of those studies looked at macrolide resistance markers. Again, these are genetic markers, not cultured isolates, not clinical outcomes, but just the genetic markers. 57 papers included macrolide resistance markers, 25 included fluoroquinoline resistance markers because that is becoming a thing. And then 22 papers included patients who had markers to both macrolide and fluoroquinoline resistance. And what you can see here in the light green on the top of these bars is the proportion that have these markers. And for macrolide resistance, that's over 40%. For fluoroquinolines, it's around 10%, and for both, it's only about 5%. But you can see that the numbers are really quite high. And if you want to look at it in a slightly different way, these are the same data from the same meta-analysis. But when you look at overall, shown on the left, you can see the time range from 2010 to 2017. You can see the macrolide resistance marker frequency on the top row going up dramatically in every place except the European region. You can see the fluoroquinoline markers that go up somewhat in the middle row, and on the bottom you can see those people who have both. I think I would point your attention to the column next to the right-hand column that is the Western Pacific region. And the reason I would call your attention there is because that is actually like a sentinel region for us, because we see resistance occur there first, and then it disseminates around the rest of the globe. So it's important that we keep an eye on what's going on all around the world. This is just to show you that distribution around the world. Macrolides on top, fluoroquinolines in the middle, and both on the bottom. But what you're seeing here is also a reflection of who does testing, right? So we don't know all of those grayed out areas. We don't know what's going on because there's no testing going on. So it is to say that if you look for these resistance markers, you're going to find them. Sorry, that's the global distribution. Okay, and so here's your prevalence based on sex and sexual orientation of these resistance markers for Mycoplasma genitalium. You can see that in the top panel where men are in blue, they have higher rates of resistance markers. They have higher rates for the macrolides, fluoroquinolines, and both. And on the bottom panel, you see men who have sex with men versus men who have sex only with women. And again, you see that we're finding these resistant cases much more frequent among men who have sex with men for any of the compounds that we're looking at. Okay, and so with that, now we know what the distribution is. We know populations we should be focusing on, and that's important for the laboratorians in the audience because you need to be able to counsel your clinical clients as to which patients they should be targeting for their testing. So let's talk about what tools we have. We have culture for Neisseria gonorrhea, which has been around forever, and it's a really great tool. The problem is we have to transport the organisms to the laboratory in a CO2 environment, and preferably a warm one, in order to keep the organisms viable. That said, if you have access to this diagnostic method, it's great if you're using it to look at test of cure. In the US and in Europe, we're recommending test of cures be done, particularly for people who have gonorrhea in the throat. And it's much better to do a culture than a nucleic acid test because the nucleic acid tests detect dead organisms. So there are some assays in development that I can talk about in more detail if people are interested in that, that will assess the viability of the bugs. So it won't just tell you DNA is present or not present, but it will tell you whether the organisms are actually viable, and that can be done with molecular methods. And so we can get rid of, depending on culture for that. However, culture is super useful for antimicrobial susceptibility testing, and in the US, for our surveillance activities, we rely on getting cultures, which is why they're from people who are known to be symptomatic. So we know that we have a high likelihood of getting a positive culture. So when we do this for AST, basically we're looking for organism growth compared to a disc containing a compound. And like here, you can see what it looks like with the disc diffusion method for a resistant organism shown on the left and a sensitive isolate shown on the right. And we measure that zone, and we use that zone to calculate back to a minimum inhibitory concentration to say how well we think these compounds are still working against the isolates. Now, I will say that it's important for you to remember these are phenotypic results, and they have a pretty good predictive value for identifying people who will fail therapy. But it is only a predictive value. It's not a one-to-one correlation necessarily. So that's important then when you start thinking about molecular diagnostics. Because when we talk about molecular diagnostics, we can detect the organism. Almost every platform available in the US has gonorrhea on it. Usually it's bundled with chlamydia, as you all know. But there are also several tests that are available at the point of care. There are 3 nucleic acid amplification tests currently on the market, one that's about to get approval, and several more that are under development. So that's a direction that will be interesting, and see how it changes the nature of test and treat. But nucleic acid amplification tests, which are the recommended class of tests for the US for detection of GC, older generations used to worry about confirmatory testing when using these tests because there were closely related species that could cross-react. However, newer generation tests use dual target technology where they actually amplify 2 different DNA sequences, and they require that both sequences be positive, and thus that serves as an internal and simultaneous confirmation. So you don't have to do additional testing to prove that the bug is there. That said, what you have to do to understand whether or not the organisms are viable is not yet available commercially. And these are the platforms that are FDA cleared, and you can see they run from a mini school bus on the bottom left, I like to call it. It takes up a huge amount of space, but it has very high throughput and high efficiencies, to the lower right, which is the smallest one we have. And the tube that's capped with blue, which is your specimen tube, is really just the length of a specimen collection swab, so it's quite tiny. The purple one in the middle right is actually no equipment at all. That's completely disposable, but it is nucleic acid amplification driven. So we have lots of options for how we can test for gonorrhea in this country. So that leads us to the resistance-guided therapy question. Should we be able to use molecular tools to detect some of these resistance markers, like I was talking about with Mycoplasma genitalium? And the answer is yes, we can. And data are becoming available, more and more data all the time, that using a rule-in approach for gonorrhea management, if they don't have a resistance marker, so if they're wild type for a mutation on the GRA gene, then ciprofloxacin should be effective. Now, this is a nice and conservative approach because even some people who have the mutation, that mutation could be a minority population and the person might still respond to Cipro, but we're not going to risk it. We're still going to give those people ceftriaxone. And so with this conservative approach, Klausner and colleagues in Los Angeles showed that when they had 106 patients who had the wild type gene for gonorrhea, they were cured after a single dose of ciprofloxacin. And this study did include a follow-up and follow-up testing. So this was a clinical cure as well as a microbiological cure. So there are very good evidence that really suggests that we could go this approach and treat people with something that's a little bit less invasive than an injectable. So the one way that this would really benefit from a point of care test is that people could actually be tested and treated correctly, but perhaps more simply if we had a point of care test. But right now, all we have cleared are laboratory-based tests, and even those don't have these resistance markers, but we don't have a point of care test for GC detection in general. But so while we're still using the laboratory test, people can still benefit from this because when we identify asymptomatic infection and those people were not treated in clinic, then it might be that if they have the wild type gene, we can actually just mail treatment to them without them having to come in for an injection. That said, there are point of care tests that are in development for both detection of gonorrhea, the ID, and for ciprofloxacin resistance testing. And this is just one example of an assay that's in development. It's quite small. You can see the blue gloved hand holding it. And it's got connectivity, so it can send results to a phone or to a computer. But this assay will detect both an NG specific sequence that's shown in red, and will also show the wild type RA gene. And so if the wild type is present, as shown in the first panel, the bug is ciprofloxacin susceptible, and you can use that instead of an injectable. But if, as in the middle panel, the bug is detected, but the JARA mutation is there, you only see a line for the bug, an amplification for the bug. And so in those cases, you would still have to use ceftriaxone. And of course, on the far right, if you see those samples where there's no amplification for GC itself, and then of course you're not going to get a JARA amplification line, and those people obviously don't need treatment. Okay, so that's gonorrhea and what we can do with it. So what about Mycoplasma genitalium diagnostics? Well, I said culture for GC was great, but culture for MGen, not so much. So this is not going to happen. It's not clinically relevant because it takes up to 3 to 8 weeks. And it really, the best detection systems rely on co-culture with mammalian cells. So it's much like doing a virology culture with an organism that's highly fastidious. It's very, very choosy about the medium that it goes in. And the sensitivity is likely still as low as about 40%. So culture is not an answer for us with this organism. And that means we rely exclusively on molecular testing. So gnats are out there and they're functional. There are several commercially available platforms that have included Mycoplasma genitalium on their assays. You can use a single genital sample and you can use it for chlamydia, gonorrhea, trich, and mycoplasma. So that's a great advancement. The real trick here is trying to tell which patients you should use this test. And normally at this point, if we're talking about other bugs, I say, and which sites you should sample. But in the case of Mycoplasma genitalium, there are only claims for genital specimens. So you should consider the positivity rate that you have in your population, and you should do some studies to understand the resistance in your population. And since none of the tests that we currently have available, some of which are shown here, you can see it's fewer than the previous slide. None of these have a resistance marker assay. There are a couple that are working on resistance marker assays, and they're in the RUO or ASR development phase. But at the current time, we don't have access to that. And so because of that, we can't do resistance-guided therapy here. And because the rate of resistance is so high in the studies that have been done in the US, it's unclear if we should test and treat with these kind of next generation or next phase, next line, whatever word we want to use, compounds, or whether we want to just not test at all. And so the CDC's recommendation, which Dr. Geisler will go into in more detail, is at this point not to test initially, and he'll give you more details on that. But in Australia, where they do actually have different assays available to them, here's a method that they're using that's working really quite well. And this is only for symptomatic patients. But if you see a patient with symptoms, particularly a man with urethritis, you will treat that person that day with doxycycline for 1 week, assuming that they have chlamydia. And they're ruling out gonorrhea via microscopy. So you treat with doxycycline for a week, but at the same time that they're there, you collect specimens and send those to the lab for mycoplasma identification, as well as looking at resistance markers. Now, this slide has been updated more recently. This is a slide from 2022. And before that, they were only checking for the macrolide resistance markers, but now they're also checking for resistance markers. So since
Bobby,
they're...
Can you advance the slide just to show them? We're actually
sorry.
Yep.
Sorry. Thank you. Thanks, Will. So, doxycycline for 7 days, send the specimen to the lab. The person, if they're positive for M. genitalium, they're supposed to come back in 7 days. And then based on the lab results, if they have the macrolide susceptible profile, then they can be treated with azithromycin. So following the doxycycline, azithromycin seems to work. If they have the macrolide resistance marker, but they are wild type for the quinolone resistance marker, then they can be treated with moxifloxacin. So these two strategies on the left both lead to a 95% cure rate. So you don't even need a test of cure with these people. Now, if they have the macrolide resistance marker and the fluoroquinolone resistance marker, You can treat with minocycline or pristinamycin, or you can stick with moxifloxacin, but minocycline and pristinamycin are not available in the US. And they have about a 70 to 75% cure rate, but moxifloxacin will be less than 50%. It's not clear that it's even worth doing it, which is one of the reasons we don't have a lot of test and treat recommendations in the US, because we don't know all of this information like they do in Australia. Okay, I'll use the right button this time. So just as a reminder, we have these macrolide resistance markers, and these markers target the 23S RNA gene, and it's very predictive of azithromycin treatment failure. None of these assays yet have FDA claims in the US. So we don't have a lot of choices, but we have a lot of resistance out there. And we need some of these newer technologies to become available pretty quickly. So with that, I'm going to turn this back over to Will to talk about testing and treating.
Great. Thank you, Bobby. So Dr. Vanderpoel just kind of, again, talked about epidemiology of resistance and the specific types of STI assays, some that incorporate resistance markers to help guide treatment. So I'm going to wrap up the last part of the presentation talking about what are the actual CDC's recommendations for testing for these common STIs and also treating for them. And so let's first talk about CDC's recommendations for testing for common STIs in these clinical syndromes. And so in new cases of urethritis or cervicitis, they recommend testing for chlamydia, gonorrhea, and trichomonas vaginalis. And if it's an MSM, the trichomonas vaginalis is not a concern, so it'd be chlamydia and gonorrhea. You see that mycoplasma genitalium is not listed. CDC does not recommend testing for it with the initial presentation of urethritis or cervicitis. Although I personally think that that would be beneficial, and some are already doing that, it's not what's recommended in the guidelines. When you have persistent or recurrent urethritis or cervicitis, that is when CDC recommends that you do testing for M. genitalium. And if you did not previously do testing for trichomonas vaginalis, then it's also recommended that you do that at this time of persistence or recurrence. You should also consider repeating the initial testing for chlamydia and gonorrhea if there's any concerns about new or repeat exposures to these possible pathogens. Now, for women with symptomatic vaginal discharge, as mentioned earlier, it's recommended that you do evaluation for bacterial vaginosis, candidiasis, and trichomonas via wet mount. But also, because of the possibility that vaginal discharge may be a presentation of these other STIs, chlamydia and gonorrhea, it's also recommended that you do molecular testing for chlamydia and gonorrhea in these women that have the symptomatic vaginal discharge. And, ideally, you would also do trichomonas vaginalis molecular testing because it's going to pick up more cases of trick than you would see on a wet mount. For women with pelvic inflammatory disease or men with epididymitis, it's recommended to do chlamydia and gonorrhea testing. In the case of PID, it's also recommended by CDC to consider doing M. genitalium testing at the first presentation of PID, which is what I would also recommend. Now, as far as some other broader STI testing recommendations, for women that are pregnant, it is recommended to do chlamydia and gonorrhea testing at their first prenatal visit if they're younger than age 25 or 25 or older with risk factors. And in the same group, you would want to retest them in the third trimester if they're younger or, again, have risk factors for chlamydia and gonorrhea. And it's because these infections, they're transmitted when a baby is born through the birth canal, they are transmitted from the vaginal secretions to the baby in the birth canal, and the baby can get infection with chlamydia or gonorrhea. Now, syphilis, we know, is a very important organism in terms of causing morbidity in newborns. It can cause congenital syphilis, which can be catastrophic. And so for that reason, syphilis testing is recommended at the first prenatal visit and to retest at 28 weeks of gestation, and even at the time of delivery for those who are higher risk for syphilis. And in HIV testing, we haven't talked much about HIV, but it's recommended at the first prenatal visit and then retesting in the third trimester for those at higher risk for HIV. In terms of men and women who are otherwise asymptomatic, so now we're talking about asymptomatic screening. For women who are under the age of 25 or who are 25 or older with risk factors for chlamydia and gonorrhea, and then all MSM, as well as men who have sex with women but are at higher risk for STIs, you would want to do chlamydia and gonorrhea testing in those populations at least annually and perhaps more frequently when needed. Trichomonas testing is recommended annually in women who are at risk for trichomonas, or in a high prevalence setting, such as a sexual health clinic, where you're going to see higher rates of trichomonas. There are no routine testing recommendations in asymptomatic men for trichomonas. Syphilis should be tested annually in women or in men who have sex with women who are at risk for syphilis, and then should also be tested annually in MSM. HIV testing should definitely be done annually in men who have sex with men, MSM. In women or men who have sex with women, HIV testing is done as an opt-out type of strategy, or certainly if you're doing other STI testing anyway, you can just bundle that and do HIV testing as part of that. And then for asymptomatic men or women, including even MSM, M-genitalium testing is not recommended when they're asymptomatic. The only exception to that would be if they're the partner, a sexual partner of a person that you know is infected with M-genitalium, and then it is recommended that you would test the partner. And so there are several reasons probably why M-genitalium testing is not recommended right now in asymptomatic persons. One of them is we don't understand enough about the natural history of M-genitalium in asymptomatic people. Does it persist for a long time? Does it lead to any important disease? Even though there's some evidence to suggest it may, it's just not definitive evidence to the point that CDC is going to recommend M-genitalium testing. And it can be quite difficult to treat M-genitalium because of resistance. And so you may end up having a person who's asymptomatic, but you might not be able to cure them. So that would introduce a lot of problems for the patient themselves, knowing that they have an infection that cannot be cured at the present time. So we just talked about CDC's testing recommendations. What about their treatment recommendations for these common clinical syndromes and pathogens? So first, the syndromes for urethritis. For a new episode of urethritis, it kind of depends, the treatment recs depend on whether you did a urethral gram stain or not. If you did a urethral gram stain, that would give you an idea about whether a patient may have gonorrhea, because you can see the gonococcal-like bacteria on the gram stain. So if the gram stain suggests that you may have gonorrhea, you should treat for both gonorrhea and chlamydia in men with urethritis. In men that the gram stain does not show gonococcal-like bacteria, you would simply provide treatment initially for chlamydia. If you don't have a gram stain, then you should most likely treat for both gonorrhea and chlamydia, certainly for chlamydia. But if you're in an area that has, higher prevalence of gonorrhea, which is most urban areas, you would want to go ahead and treat also for gonorrhea. And in my practice, I would say that most people, if they don't do a gram stain, but they document urethritis, they're going to treat for both gonorrhea and chlamydia. Persistent recurrent urethritis in men is quite challenging. I'll just try to summarize it by saying that if you think a person's simply been re-exposed to an untreated partner, then do the testing for, or guide the treatment towards chlamydia and gonorrhea again. And if you did not do trichomonas testing initially, you would probably want to add trichomonas treatment in men who have sex with women who are coming in with persistent recurrent urethritis. If you did the trick testing and it was negative for trichomonas, and they were, of course, negative for chlamydia and gonorrhea, then there's a pretty good chance it's mycoplasma genitalium in that sense, in that scenario. And then you would want to provide M-genitalium treatment as well as get your testing for M-genitalium for that persistent recurrent urethritis. I think Dr. Vanderpool mentioned earlier that if you have suspected gonorrhea treatment failure, you would want to get a culture on these individuals, but you also want to treat them again for gonorrhea. So for CDC's recommendations for treating cervicitis, it's much like the urethritis recommendations. For new cervicitis episodes, you would treat for chlamydia always, and in most of the settings that have higher gonorrhea rates, you would, or gonorrhea prevalences, you would also treat for gonorrhea. And if you're really not sure how common gonorrhea is in your population, you should always err on the side of treating not only for chlamydia, but also for gonorrhea. For women who have persistent recurrent cervicitis, if the M-genitalium testing is positive that you would do when they present at that time, then it is recommended that you test them for M-genitalium. If you didn't do a trichomonas molecular test at the first presentation of cervicitis, even though we don't think of trick being a common cause of cervicitis, you should certainly test them for trichomonas at that time point and have a low threshold to treat them as well. As far as gonorrhea treatment, the data that Dr. Vanderpool showed you, illustrated that resistance to ceftriaxone really in all populations is quite low in the U.S., and that's why ceftriaxone is recommended, the only first-line recommended antibiotic for for treating gonorrhea at all the sites at 500 milligrams intramuscular times 1 dose. And for patients that weigh more than 150 kilograms, it's actually recommended that you give them a full 1 gram of ceftriaxone. Alternatively, if there's some reason that you cannot give them IM ceftriaxone, then an option would be oral cefixime, which is not as good, but it is an option, or giving them combined IM gentamicin plus oral azithromycin. Azithromycin dose is 2 grams for gonorrhea treatment compared to the 1 gram that we use as an alternative treatment for chlamydia. I'll point out that if a patient has a cephalosporin allergy that's serious, then you would want to use that gentamicin azithromycin regimen. Now, you don't see the quinolones like ciprofloxacin recommended by CDC for treatment because, as Dr. Vanderpoel showed you, the quinolone resistance rate is fairly high. It's about 30% based off of these markers, the cipro resistance markers in GIRA. However, I think you can expect in the future, as these newer tests evolve and start incorporating these quinolone resistance markers, that these guidelines will be adapted to incorporate the option of using ciprofloxacin when you have a point-of-care test that shows that patients don't have the cipro resistance marker, because it's single-dose cipro and it's a very affordable, very easy to take. Chlamydia treatment, the only first-line antibiotic is doxycycline for 7 days. It turns out that for the most part, even if you don't even take the full 7 days, pretty much most patients are cured. And some are going to be looking at even shorter treatment regimens, as short as maybe even 3 days in the future. And so doxycycline is clearly the best chlamydia treatment. Alternatively, you can use azithromycin 1 gram given single dose therapy. Ideally, you want to watch the patient take their 1 gram of azithromycin. And for pregnant women who we don't want to use doxycycline in, azithromycin would be the recommended regimen. As far as trichomonas vaginalis treatment, it used to be metronidazole 2 grams single dose for both men and women. But in recent years, there's been clinical trials illustrating that metronidazole for 7 days in women is more efficacious against trich than the single 2 gram dose. And so the current guidelines recommend the 7 days of metronidazole for women for trich, but only 2 grams in the men of metronidazole, again, because of lack of data in men showing that 7 days is better than a single dose of 2 grams. But that data is coming. One of my colleagues is doing a study in that area, and I expect by the next guidelines that might be updated. Alternatively, tinidazole, which is closely related to metronidazole, would be an option in non-pregnant individuals that you can just take a single dose treatment. It's more expensive, but it's more convenient. So Dr. Vanderpoel mentioned this strategy for treating M. genitalium called resistance-guided sequential treatment, which is basically where you do genotypic resistance testing for macrolides, and that will help to guide you about whether you have a macrolide sensitive or resistant strain as to which treatment you should use. So CDC follows that rationale by saying that if you actually have access to MGent resistance testing for macrolides, if it's macrolide sensitive, give them 7 days of doxycycline to lower the bacterial load, and then give them an extended course of azithromycin, where you basically are going to give them 1 gram on the day 1 and then 500 milligrams a day for the next 3 days. But if the macrolide resistance assay shows that you do have a macrolide resistance marker, then you give them 7 days of doxycycline and you then go straight to moxifloxacin for 7 days. Now, Dr. Vanderpoel mentioned that there's no FDA-cleared M. genitalium NAT that detects resistance markers. I will mention at UAB, our Mycoplasma lab does have a validated assay. It's not FDA-cleared, but it is validated for clinical care that detects macrolide and quinolone resistance markers. So if that's something that you want done, you can look that up. You can Google our website, and you can send us that specimen until the FDA-cleared tests come out that include these resistance markers. But many individuals who are treating these patients don't have access or don't know about our assay, and so they're simply having to do empiric treatment for M. genitalium. And because macrolide resistance is so high, the CDC would recommend if you don't have that macrolide resistance marker data, then just give them 7 days of doxycycline followed by 7 days of moxifloxacin. For PID treatment, you want to give ceftriaxone IM times 1, along with 14 days of doxycycline and 14 days of metronidazole. It used to be optional about whether you add the metronidazole, but a recent PID clinical trial showed that women had better outcomes if you added the metronidazole, both clinical outcomes and cure of anaerobic bacteria. And so it is recommended now to give the metronidazole along with ceftriaxone and doxycycline. I think this is one of my last slides, just some other basic STI management considerations that usually our approach is to treat the sexual partners of patients who have a documented STI as presumptive treatment without even waiting on testing. M-genitalium is the one exception that the CDC guidelines suggest that not just routinely testing a partner of an M-gent infected patient, rather test the partner first, and then if the partner is positive, then you treat the partner. The reason why, I think primarily, is because one of the main treatments, moxifloxacin, it's more expensive and it has potentially some more serious side effects that are rare, but they're still serious. And so I think you want to be sure that really the partner has that before you treat them for M-genitalium. And in general, for these common STIs, we don't do a test of cure in non-pregnant persons if they are clinically cured with resolutions of signs and symptoms. I think the exceptions to that are you do a test of cure for chlamydia in pregnant women just because of the potential prenatal complications. And you do that test of cure 4 weeks after therapy. And then I forgot to list this on the slide, but Dr. Vanderpool mentioned the CDC guidelines also do recommend that for pharyngeal gonorrhea, that you would want to routinely do a test of cure, and you would want to do that ideally by culture. And then for individuals who test positive for chlamydia, gonorrhea, or trichomonas, CDC recommends repeat testing 3 months after treatment, and that's because the reinfection rate with those organisms approaches about 20%. And so it's common enough that it's worth doing the repeat testing. So let me just kind of summarize very quickly. We talked about common STIs. Specifically, we said chlamydia, gonorrhea, and mycoplasma genitalium are common causes of urethritis and cervicitis, and also may be associated with vaginal discharge. Trichomonas causes urethritis in men who have sex with women, as well as causes vaginal discharge. Dr. Vanderpool highlighted that antimicrobial resistance is a very important concern for gonorrhea and mycoplasma genitalium. We didn't talk about Trichomonas vaginalis resistance to metronidazole. It's overall quite rare, but that does happen. And so that's something you'll hear more about, I think, in the future if it becomes more common. Dr. Vanderpool highlighted that NAT is, which is a molecular test, is a recommended diagnostic test for these common STIs, except for maybe the exception of doing gonorrhea culture when you want to look at resistance. And that she highlighted some of the newer approaches that are going to incorporate resistance markers to help guide the treatment of these common STIs. And then finally, I just summarized CDC's guidelines recommendations for testing and treatment of these common STIs. And so I definitely encourage you to keep those guidelines close. There's actually an app that you can have on your phone that's really easy to use with the guidelines. I have that on my phone, so it's something that you may want to consider. And on that note, we will stop and take any questions and comments that you may have. Thank you so much.
All right. Well, thank you so much, Dr. Geisler and Dr. Vanderpool, for your informative presentation. We will now start the live Q&A portion of the webinar. So to our audience, if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. Our first question here asks, do you have any advice on how you can manage these more resistant infections?
Yeah, so I'm happy to talk about that one. Mycoplasma genitalium is very difficult to manage. I think as Dr. Vanderpool showed you the data, we are already seeing strains that have both macrolide and quinolone resistance. And so typically when we have them, they're failing the doxycycline azithromycin regimen and the doxycycline moxifloxacin regimen. So minocycline, which actually is available in the U.S., it's an older tetracycline, is really our go-to drug in the U.S. in non-pregnant individuals who have failed azithromycin and moxifloxacin regimens. Even though it's related to doxycycline, it has a little bit better activity against mycoplasma genitalium. And so if you give it for 14 days, we've had pretty good luck curing about 75% of those infections. Outside of that, it gets really, really difficult. And I can tell you that there are no published studies on clinical efficacy of other agents in the U.S. from the ones I just talked about. We know if you look at data in vitro that tinidazole, which is again related to metronidazole, has some activity against M-genitalium, as does a newer tetracycline called omadacycline. But whether either of those two are going to work, we simply don't know because we don't have published data. Trichomonas, on the other hand, for patients who fail the typical 7 days of metronidazole, Usually, if we push higher doses of tinidazole up to 2 grams a day and give a patient up to about 7 days of the tinidazole at 2 grams, that usually is sufficient to cure them. And if it isn't, then you really need to reach out to an expert in trichomonas. And I would recommend Christina Musney, my colleague here, who can actually get access to do resistance testing for trichomonas. Gonorrhea resistance is quite rare, but if patients fail ceftriaxone, I would honestly reach out to a local expert to get guidance, because it gets quite complicated. If they fail ceftriaxone, it might be very difficult to eradicate. And sometimes we have to come up with creative regimens, sometimes rarely including IV therapy, to be able to get rid of gonorrhea that's resistant. Fortunately, in the case of chlamydia, we don't really have resistance issues there. So that's kind of my approach, at least for those who are in the US. That's how I would approach treating these more resistant STIs.
And I will say there was a recent case of a death due to disseminated gonococcal infection that, just couldn't be treated. And it's difficult to really understand whether it was really that resistant or if it was just not recognized for what it was in time. So it's a complicated case, but, it is important to pay attention to these as these infections can become disseminated.
Great, thank you. All right, our next question here asks, pulled the wrong one here. Let's see, how does testing for fluoroquinolone and macrolide resistance align with current STI management guidelines, and are there evolving recommendations?
I guess I might cover that one, just since I talked a little bit about this. And so, the current guidelines, they're not incorporating quinolone resistance mutations yet. These were, even though they were published in 2021, all the literature review and all the discussions going into those happened even starting a couple years before the guidelines. And so the current CDC guidelines really only incorporate the macrolide resistance testing, and they do give you specific guidance about which regimen to choose if you find macrolide resistance or not. And that's kind of obvious. If you don't have macrolide resistance, it's doxy plus azithromycin. If you do have macrolide resistance, it's doxy plus moxifloxacin. The challenge about quinolone resistance markers, and Dr. Vanderpool may want to expand on this, is that unlike in macrolides, when you have the resistance markers, we know the treatment failure rates are very high, typically over 80%. There are several different quinolone resistant mutations that have been reported, not only in GIR A and PAR C, but even in other quinolone resistance areas. And so they don't always correlate with treatment failure. So just because you have a quinolone resistance marker doesn't mean that it correlates with treatment failure. So it makes it quite difficult for CDC, who only puts out guidelines, about every 5 years, to start recommending to look for a specific quinolone resistance mutation when it's a moving target. And so I'm not quite sure how they're going to handle this in the newer guidelines, but right now they really don't address how to treat quinolone resistance markers. Dr. Vanderpool, did you want to add anything to that?
No, other than to say that's exactly the same problem we have, for example, with penicillin resistance, because it's not just the mosaic gene, but there's a lot of different places you can have penicillin resistance mutations, but to capture them all in one assay is never going to be possible. And just because somebody has one of the mutations doesn't mean they'll be resistant. And so using these molecular tests, I think it's really important to remember that we have gotten further and further away from clinical outcomes. And that's why I think we really have to look at where people have used the molecular tests and have done follow-up studies to try and understand how the molecular tests predict clinical outcomes, because that's what we really care about, right? So it's really hard, and it's something that we would need to put some serious research effort.
Great, thank you. We have time for a few more questions here, so we'll continue. This next question asks, what is your recommendation around drug resistance, isolate or directly from clinical specimen by PCR?
So it depends on the organism, right? So if it's gonorrhea and you can get an isolate, that's always ideal. It's ideal for actually understanding a resistance profile. However, if you really want to test and treat the patient quickly and test and treat them appropriately, a molecular test is probably a better bet because the isolate's going to have to take time to be grown, to be cleaned, and then to do either AST or E-test, whichever one that you're doing in your lab if you do cultures. And finding a lab that can do cultures is quite difficult. For Mycoplasma genitalium, while we can look in those labs, like Dr. Geisler's lab here at UAB, that can isolate via culture, even so, they don't always get a positive from every specimen. And they can use those specimens then to look at resistance profiles. But again, it's such a time-consuming and awkward process that it could be 3 months before you actually know the resistance profile from a person. So molecular tests for mycoplasma are always going to be the way to go for patient management purposes, not necessarily for epidemiology purposes, but for patient management.
And trichomonas would be culture. You would need to culture that.
Yeah, trichomonas you would want to culture for sure. Although there are some markers that are becoming better defined, I don't think that we're ready for that yet.
Great, thank you. All right, now aside from specific chromosomal drug resistance genes, can you comment on the ability to link drug resistance markers to NG and MG in non-sterile samples like genitourinary tract samples?
Well, so these resistance markers that we're looking at can come from non-sterile samples like vaginal swabs or urine specimens that are first void urine. So non-sterile samples, um, and that's hey Mike, how you doing? Sorry for the aside. But yeah, so we can look at these in non-sterile samples, and that's the joy of using PCR type technologies, right? So, and there are other technologies that are coming along, including the viability assays that I think will continue to expand our knowledge about what we can do with these. I think the other thing that would be really exciting is if someone developed biomarkers for resistance, so we weren't having to necessarily look at the genetics of it, but we could look at maybe some metabolomics or other techniques that we could use that might be just as efficient from a molecular standpoint, but actually be more specific to the organism and the compounds we're concerned about.
Great, thank you, Dr. Vanderpool. All right, next question here asks, do insurance providers cover the costs of mycoplasma genitalium, macrolide resistance, and fluoroquinolone resistance nucleic acid amplification tests?
There's a really easy answer for that one, and it's no.
Yeah, I mean, I would say, well, it's not always no, but I don't think you can count on it. I think in rare instances that they actually have covered at least the cost of the test, but in terms of the tests that now incorporate these resistance markers, no, they're not probably going to cover that.
Yeah, and the reimbursement for mycoplasma genitalium in general has been pretty weak, and most third-party payers are falling back on the CDC guidelines to say that, did you go through steps A, B, and C before you tested for this? And if you didn't because you screened up front for it, they're just going to deny it. So it's going to be a one-on-one basis that you're going to get it to pay for it. But the general assumption that you should have if you're offering it to your patients is that your patients are going to end up getting a bill.
Yeah, I mean, I have seen some companies cover it, but it's been less common than the more common.
Great. All right, well, thank you guys again for your time today. This will conclude our session. So Dr. Vanderpool and Dr. Geisler, do you have any final comments for our audience?
I would just say that we live in a very exciting time, and so we talked about a lot of the barriers and a lot of the things that we are concerned about, and we want to make other people aware of that they should be considering. But that said, I think there's not a lot of development in terms of new antimicrobials, and that's a shame and a concern. But there is a lot going on in the diagnostic arena, and so I think better and better tools are on the way. And so over the next 2 to 5 years, I just expect us to see an explosion of options for helping us to manage patients better and really, try and reduce the number of infections, both in the US and globally.
The only thing I want to add is that I didn't really have time to talk about this today, but partner management is really an important facet of this. And now, pretty much almost every state, I think, in the US now approves the use of expedited partner therapy, which typically means a patient is given medicines to give to their partner. So we need to do a better job managing the partners. I think that will help.
Mhm.
Great. Well, again, I want to thank you, Dr. Geisler and Dr. Vanderpool, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Applied Biocode, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.
Thanks, everyone. Bye.